We have several interesting new developments in headache within the last month. This would have been September of 2023 because there was an International Headache Congress in Seoul, South Korea. At that Congress, two important studies were presented. One was a phase 2 randomized controlled trial, placebo-controlled trial on a new target in migraine prevention. That target is pituitary adenylate cyclase-activating polypeptide, or PACAP. And we've been wondering whether PACAP might be a reasonable target for preventing migraine. It is released in the meninges and dura, similarly to CGRP. And infusion of PACAP causes migraine in those with migraine, or at least headaches that look like migraine, within 2 to 4 hours. So it does seem like a reasonable target. However, one previous study, a phase 2 trial against one of the PACAP receptors, was negative. A different company developed a monoclonal antibody against the PACAP ligand, and this phase 2 trial was that study. It was about 245 patients. There were 3 arms: a high-dose PACAP infusion, a low-dose PACAP infusion, and a placebo arm. There were about 100 patients in the high-dose and placebo arm, whereas there were only 46 patients in the low-dose PACAP arm. And the patients received a single infusion or placebo and were followed for 12 weeks. The primary endpoint was the reduction of mean monthly migraine days in the first month, and that was very significantly positive for the high-dose PACAP group. The study involved patients with episodic and chronic migraine, and the average number of monthly migraine days at baseline was over 16, so in the chronic migraine range. And the drop from baseline for both the high-dose and the low-dose PACAP groups was 6 days from the baseline, so down to about 10 migraine days per month. The low-dose PACAP arm was not statistically significant, but as I said, there were only 46 patients in that arm, and it missed significance by what looks like maybe 1 patient, because the magnitude of drop was the same or almost the same as the high-dose PACAP group. This was only a presentation. The adverse events were described as being of no consequence. It looked safe and well tolerable, but obviously we need a larger study, a phase 3 trial, to work out what dose would be reasonable and to really evaluate for adverse events. But I have to say, this is very exciting because we do have patients that don't seem to respond to the anti-CGRP drugs. This represents a new target. The patients that were involved in this study had between 2 and 4 preventive medications fail in order to be actually enrolled in this study. So they were a little harder to treat patients, and that also is a good sign. So I look forward to a phase 3 trial with this monoclonal antibody and hope that we have a new target in migraine prevention. The second study that was presented at the International Headache Congress was a simultaneous study of patients on atogepant for migraine prevention using ubrogepant as needed. There always seems to be a question whether it is safe to use one Gepant on top of another Gepant, that is, one Gepant for prevention and a second Gepant for acute usage. This study, which was ongoing and involved quite a number of patients, was open label but did not report any safety or tolerability issues. It was a little bit limited because, as it turns out, the patients responded so well to the atogepant that the ubrogepant use was rather infrequent. But based on what was taken in the study, there didn't appear to be any safety or tolerability issues. Neurologists around the country are combining monoclonal antibodies and Gepants. We have lots of case series on that. Botulinum toxin A and Gepants, monoclonal antibody monoclonal antibodies and onabotulinum toxin A in prevention, and preventive Gepants with as-needed Gepants on top. So this is widely being done, but it would be nice to have a large safety database with which we could justify this, both for efficacy and safety and tolerability. And I hope we'll get the full study published so that we can review all the data from it.